All right. I'm Dr. Irvin Sani. I'm going to talk a little bit about minimally invasive surgery, but I want to make a point for everyone to understand that surgery is always absolutely the last option. When I first came to this area, I did only spine surgery. I was primarily a spine surgeon. What I started to realize over time was that it really limited what I was able to do for patients, and it really bothered me. And I felt like the toolbox, the things available to me to treat my patients was very limited. And so a few years after I started practice, I started to do interventional pain management and really appreciated the ability to make patients better in many, many different ways, including spine surgery when it's necessary, of course. Dr. Zarsa and I were residents together at Baylor College of Medicine in Houston, and so I've known him for a very long time. And when we decided to partner up, it was because we shared the same philosophy. Dr. Zars didn't mention this, but he believes very strongly in nutrition, and I really appreciate what Kara and Ashley both had to say about nutrition and exercise, which really is probably the most important message that you can get here today. When we do injections, when we do these different treatments, those things are really just to try to improve symptoms. The real way to improve your back pain is what Kara and Ashley talked about, and that's weight loss and nutrition. You've got to absolutely treat your body as a temple. And that is absolutely the number one most important thing you can do to improve your back pain. We can give you shots until we're blue in the face and even do surgery when it's absolutely necessary. But if you don't take care of yourself, if you don't get the appropriate amount of exercise, hydration, and nutrition, then really these things that we do are ultimately not going to have any real long-term benefits. So I just wanted to mention that and just really emphasize the importance of preventative health. And that's why I really love this hospital. I really like what Resolute stands for. That's what really attracted me to this place. Their position on nutrition, their position on preventative health is very inspiring, and you just don't see that a lot with other hospital corporations. So, minimally invasive spine surgery. I've watched spine surgery just like I've watched computers go to iPhones. I've watched spine surgery change over the last decade and a half. I was actually involved in Houston. I went to Baylor College of Medicine, like I mentioned, and we were actually doing the very first kyphoplasties in the country before it was FDA approved with a doctor there named Dr. Esses. And so I watched some of the minimally invasive spine surgery develop, and we were actually doing kyphoplasties before they were even available for doctors to do, before they were actually approved as a procedure in this country, and that was about 1998. And of course, I've seen maximally invasive surgery, if you will, which is sometimes still necessary. So, like I said, that's why I've changed my practice the way I have, because one size doesn't fit all. Some people need injections, and some people need big surgery, and some people can do well with small surgery, but there's definitely been a trend towards smaller incisions and towards less blood loss and less muscle trauma, less damage to the body, and faster recovery. And that's been very exciting. It's really been exciting to see. Let's go to my first slide. Okay, so these are some of the benefits. Now we're speaking specifically we're comparing minimally invasive surgery, small incision surgery, which in some cases can be about 18 millimeters, less than an inch, versus an open procedure, which can be many inches, to achieve the same thing in an open procedure. Obviously, incision isn't the most important thing, but there's reduced recovery time, of course, the smaller incision, less blood loss, less pain, shorter hospital stays. And in fact, we used to do discectomies 20, 30 years ago through an open incision. You'd spend 4 or 5 days in the hospital, and now I have patients go home within 1 or 2 hours after having a minimally invasive discectomy. It's on par with a knee scope or something of that nature. You also are able to preserve anatomic structures, and I think this is a lot of people, when they talk about minimally invasive surgery, they don't emphasize this enough. This is really, I think, one of the reasons that minimally invasive surgery is so attractive, is that you're not destroying the anatomy. You're not creating differences in the anatomy that cannot be repaired, cannot be resolved through just putting screws and rods in someone's back. And that leads me to less trauma, for sort of a similar issue, less trauma to the soft tissues. We also see people who have a reduced need for postoperative medications. We recently had a patient here at this hospital that we did a minimally invasive fusion, where we put screws and rods in her back, as well as a an implant that would typically be done, and we actually have the system that we use back here on this table. If anyone wants to go back and take a look at it, it might scare you, but it really is a smaller incision. And that patient did really well, as opposed to being bedridden for days and having maybe a 7-inch incision. It really depends on the size of the person. The bigger the person, the larger the incision has to be able to get the same exposure. And a smaller person maybe gets a smaller incision. But certainly, she went from probably a 7-inch incision, and we did it in about 1.5 inches to 1.75 inches, and lost about 50 cc's of blood instead of, in some cases, as much as a liter for an open procedure. She was up and walking the next day. Actually, she was up and walking 2 hours. Dr. Zars was with me. 2 hours after surgery, and she was completely off pain medications in 10 days. That's unusual. She's the exception. She's not the rule. But she clearly did much better than if we had done open, much, much better. And most patients are to go in that direction. And of course, a reduced overall cost, if you look at the return to work, you look at the reduced disability, and we see this over and over again when people have smaller incision surgery. This is really where minimally invasive surgery started. This is called a tubular retractor. And this tube right here is that hole right there in that person's back is about the size of a quarter. Now, you're not putting hardware and someone through this hole, but the point is that you're able to get in through this extremely small hole. Again, that's about, can be as small as about 14 millimeters actually. That probably is an 18 millimeter tube. And so instead of having to peel the muscles off of the bone and do what's being done here, severe trauma, change the anatomy permanently, you're able to split the muscles without burning them. And I've done these minimally invasive discectomy cases, again, with 10 cc's or even 25 cc's of blood loss. And just for reference, a tablespoon is 15 cc's, and so that's not much blood. But this is just to compare the difference in the way we did surgery classically versus how we've done it for about the last 15 years or so. And again, this is just showing you, again, through the tubular retractor, the smaller incisions, and that we're able to get the same thing done. And one of the beauties of minimally invasive surgery that's really interesting is you think, wow, if someone's too heavy, if they're too fat, they can't have minimally invasive surgery, but that's actually not true. And what's really beautiful about it is that the incision doesn't change because you just go longer and use the same aperture here with this minimally invasive tubular retractor. And so this is what started happening. I believe that it was Dr. Foley, at least he was one of the pioneers of this type of surgery. And this was just for a minimally invasive discectomy. This evolved into being able to, and I don't know if I have slides of that or may not, but this evolved into being able to put hardware into people through not an incision quite this small, but through incisions that are maybe twice this big or maybe 3 times this big. And so I don't want to get too technical, but this is how it's done. So instead of splitting someone open and having to peel their muscles back to be able to see the bony anatomy, you instead slide this tubular retractor down to the bone, and instead of having to peel muscles off of bone to get the exposure to visually see what you need to see, you use a neurosurgical microscope, most of us do, and I think it's a big advantage. And you're able to do work through a very, very small hole regardless of the depth. So again, like I said, as a patient gets bigger, the incision has to get bigger to get an adequate amount of exposure. And in this case, these tubes are being used to place an implant in between the vertebral bodies to fuse them together. We don't necessarily need to get into that, but the point is that you're able to do what was typically done through a much, much larger incision through a very, very small incision. In some cases, people go home, the next day after this procedure. This is just more pictures of the same thing. This is an incision, the classical incision. You're having to split the muscles, peel them off of the bone. This is very traumatic. This is probably what causes most of the postoperative pain in the first year or so, is the fact that you're having to peel these muscles off. It really, really disturbs the muscles. It creates a lot of spasm. It creates a lot of scar tissue. And I think that is where most people's postoperative disability comes from in the long term, certainly in the first year. A lot of people, their muscles will scar back down, but it's really not the same. When you use a tubular retractor, you split the muscles. You never peel the muscles off of bone. A very small amount of muscle gets taken off of bone at the very tip of the tubular retractor, but it's a fraction of a percent compared to the open procedure. I think the most important thing that you can take away from this talk today is to understand what symptoms you might have. We don't expect you to understand all the anatomy that Dr. Zars went over, or to understand what your MRI looks like, or even your x-rays. But if you can just remember that if you have sudden, especially if you're over the age of 60, sudden onset of pain in your back, that could be a vertebral compression fracture. And we see these misdiagnosed, and undertreated all the time. So it's important for you to understand if you have acute pain, that maybe you need to give us a call or talk to your primary care doctor. Just ask them for an x-ray. Just ask them to do an x-ray. If you have pain down your leg, that could very well be either facet pain, or it could be a pinched nerve in your back, like Dr. Zars talked about. If you bend over to touch your toes and you have pain, that's more likely to be your disc. Or if you have pain from sitting for prolonged periods of time, that's more likely to be coming from your disc. If you have pain when you lean back, that's more likely to be coming from your facets. As Dr. Zars mentioned, when you have arthritis in your back, we're typically talking about your facets in your back. And so leaning back facets, leaning forward discs, pain down your leg is a pinched nerve, and the same thing in the neck. If you extend your neck or bend your neck and you feel pain in the muscles of your neck or down near your scapula, that could be facet disease. And if you have pain shooting all the way down your arm, that could be a pinched nerve in your neck. This is just a picture of us working through the neurosurgical microscope here and doing a minimally invasive procedure. I think it's a discectomy. Next slide. Okay, any questions about minimally invasive surgery?
What do you do about osteoporosis? Lumbar stenosis.
Okay, so lumbar stenosis, depending on how severe the lumbar stenosis is.
Pretty bad.
Yeah, so it sounds like you might have lumbar stenosis. So what happens with lumbar stenosis? Lumbar stenosis is very common. As you get older, the facet joints that Dr. Zars was mentioning become larger, and the canal, or the space available for your nerves, shrinks dramatically. And that's not just from the joints, that's also from soft tissues such as something called the ligamentum flavum, or yellow ligament in Latin. And it really puts pressure on the nerves. Think of your nerves in a straitjacket. And what's interesting, which really makes lumbar stenosis somewhat difficult a lot of times for someone who's not a specialist to diagnose, is that it's a dynamic problem. In other words, when you're sitting, you don't necessarily have a problem. Okay, it's like having a weak muscle that doesn't. Say you have a problem with oxygenating your muscles. You don't feel that if you're at rest because there's no demand for oxygen. But when you start to walk. Now, so you may see a doctor, you may say, hey, I have this pain in my legs when I walk, and then when they examine you, they see that you have normal strength, and they're like, what's this guy talking about? This doesn't make any sense. Well, what happens is when you walk, you strangulate the blood supply, basically, to those nerves, and so they become very tired. And so you get something called neurogenic claudication. So it's another fancy word, but basically what it means is the nerves become hungry for nutrition, for oxygen, for glucose, basically for blood flow. In the case of severe lumbar stenosis in a person that's older that affects multiple levels, minimally invasive surgery may not be the right choice. If someone had 1 or 2 levels of stenosis and I felt that it wasn't too severe, I have treated it with minimally invasive surgery. But for treating your lumbar stenosis, minimally invasive surgery could be an option. But it's very common for severe lumbar stenosis or that affecting multiple levels, probably safer to do it through an open procedure because it's such an extensive decompression, depending on how severe the symptoms are. Anyone else have questions? Yes?
What's the typical rehab time after minimally invasive surgery?
If you look at people who have minimally invasive surgery versus open surgery, at 1 year, they're generally about the same. Okay, so it's not like people who don't do minimally invasive surgery are bad people. Ultimately, the results of the surgery are going to be the same. But what you can definitely say is their rehab time is quicker. They leave the hospital faster. Their blood loss is less. And what I don't really see in the literature people talking about is the preservation of the anatomy. I think we're eventually going to start seeing studies that really prove that there's preservation of the anatomy. But I can tell you from our personal experience, I think that our patients are back up and moving twice as fast, at least twice as fast, and in some cases, people take days after an open procedure to even get out of bed. And minimally invasive, now, I understand that everybody's a little different. Some people have really poor pain tolerance, and whether you do it open or minimally invasive, they're going to have a hard time getting out of bed. And there's going to be some really tough people, if you do it open, they're going to hop out of bed pretty quickly. But you definitely are disrupting a lot less when you do it minimally invasive. People seem to get out of bed and go home maybe in 1 day or 2 days, whereas when you do it open, they go home in maybe 2 to 5 days, depending on the extent of the surgery. Yes?
Unfortunately, I've had all this surgery. I'm fused from L1 up to T7. Now I'm having pain up there. They inject the facet joints, but it's not helping. Where do I go?
So I don't know your problem specifically, but this brings us to a concept of something called adjacent level disease. And again, this is why we, Dr. Zars and I, believe very much in non-surgical treatments. And I don't know what your story was. I'm not saying anyone did surgery on you they shouldn't have done. But this is one of the problems, is that when you fuse someone's spine, especially at this number of levels, now the flexibility that occurred in those levels has to be made up for. In other words, what's interesting is people have relatively large fusions and they can still touch their toes. You're like, well, how are they able to do that? I thought they were fused. Well, it's because the levels that aren't fused now do twice as much work. What does that mean? Those discs are going to wear out faster and you're going to get what's called adjacent level disease. Fassett malalignment is probably what's happening. You said T7. So despite the fact that your rib cage is splinting you, like Dr. Zars mentioned, you're probably starting to have some breakdown at that level. Unfortunately, what a lot of, and I'm not saying it's the wrong answer, but your spine surgeon is going to tell you, well, you need to have more surgery. We need to extend the fusion higher, and we've literally seen people go all the way from their neck down to their bottom. And so certainly you've had facet injections. I would certainly consider, obviously, changing my nutrition. I realize that's probably not going to help much. This is an extreme case. Exercise, strengthen those muscles as best you can. A radiofrequency ablation might be something. If the facet injections are effective even for a short period of time, then burning the nerves that feed those facets, if you haven't had that done, could actually give you some longer term relief. Because what we do, like Dr. Zars talked about, is we numb up the nerves with the medial branch block. That's just a test. It's not meant to treat people. We have that miscommunication with people all the time and say, you injected me and my pain went away and then it came back. Well, that's what it's supposed to do. We're trying to prove that's where the pain's coming from. Lidocaine, just like it does in my wife's dental office, is only temporary and it wears off. So when we go in with the RFA needle, radiofrequency ablation, now instead of trying to numb that nerve for a couple of hours, we're trying to burn that nerve, and it's just a nerve that all it does is supply pain to that area. It doesn't do anything else. You don't walk with it or pee with it or eat with it or anything like that. It's simply going to cause pain in those joints. So people are always scared, you're going to burn my nerves, aren't you going to paralyze me? No, but you could go in and burn the nerves that supply the joint that's causing you pain, and that may help. It may at least reduce the pain. Do you have any thoughts on that, Dr. Zars, for her?
I agree. I was thinking the same thing.
What is that called?
Radio frequency ablation, RFA. And it's been around for quite a while, and we do a type of RFA that's very unusual called genicular blocks. And we've got dozens and dozens of patients that we've prevented from having to have a total knee replacement because we go and burn some key nerves in their knee, and as long as you don't have instability or malalignment, I'm just saying that radiofrequency ablation can be used to treat pain at other places in the body besides the spine. It's very useful.
Is there any incapacity from that procedure, or?
No, the nerves that we burn are purely sensory nerves. So like I was saying earlier, because it's not a motor nerve. So a motor nerve is what allows you to walk. A motor nerve is what sends a message to your muscles so that you can flex your leg and walk. A sensory nerve is just what takes a pain signal and transmits it up to your brain. And so the medial branch that comes off of your radicular nerves in your spine is purely a sensory nerve, and it only provides sensation to the facet joints in your back. And so when we burn the nerve, we're not taking away the sensation for facets throughout your entire spine. We're only burning that one level. So in her case, if we're after T7, we're able to selectively ablate or selectively burn just the nerve at the level where you're having the pain, having absolutely no effect on the rest of your spine. So it's a very specific, selective treatment for a specific level in your back. And it's very effective for some patients. It doesn't work for everybody, but if it doesn't work, you don't have screws in your back, you don't have a big surgery.
I already have those.
Yeah. Does that answer your question?
Yes,
I'm interested in the knee part.
Okay.
I didn't know I was going to hear this.
Yeah, you can go to our website at spinecenteroftexas.com. That mainly has information about spine on it. I don't know if we have anything about genicular RFA on there. But we have literature in our office. You can call the office. Dr. Zars is very adept in that pain procedure. The block takes 10 minutes, and the burning of the nerve takes maybe 15 minutes. I mean, it's pretty quick. You're in and out pretty quick.
Once it's burned, what is that?
No, it can grow back. So typically people will have relief whether you burn the nerves in their back or you burn the nerves in their knee. The pain will go away for about a year to 2 years. And then you sometimes have to come back for a touch-up, if you will, because depending, a young healthy person's nerves grow back a lot more readily than someone who's older, but there's still, there's no guarantee. But again, we're talking about having a repeat procedure in a year. I mean, if your pain's gone for a year, you're usually pretty happy.
Is Medicare covered?
It sure does. Anybody else have a question? I'll try to stick to spine. Yes, go ahead.
You said you have a friend here that's a chiropractor, so clearly you advocate chiropractic care.
Absolutely.
Okay, I'm currently receiving chiropractic care for lower back pain, but my relief is lasting 2 to 3 weeks. And I'm revisiting, and I've been getting that kind of treatment for a long time. At what point do you need something more?
That is a really, really difficult question based on just the information you gave me, but I'll give you sort of a general rule of thumb. Certainly if you're having weakness like you can't lift your foot up, you need to see somebody besides a chiropractor immediately. If you're having any changes in your bowel or bladder habits, then you certainly need to be, but if you're talking just purely about back pain, you go in, you get an adjustment, you get better for a few weeks. I mean, I don't know why someone would go more than, if the pain's pretty consistent, it's hurting more often than it's not hurting, why you wouldn't seek the source of the pain maybe after 6 weeks to 3 months. Greg, do you have any opinion on that? Greg is a chiropractor as well as works in our practice. Do you have anything to say about that? Get the chiropractor up here to answer that question.
That's right. Okay, as Dr. Sonny was saying, I'm Dr. Greg Nelson. I'm a chiropractor. I'm also a family nurse practitioner. I've been with his practice for about 2.5 years. So I've got a 20-year history in conservative management of primarily back problems, but then expanding my scope as a nurse practitioner allows me to work with these great guys. So the answer to your question, I'm going to change the direction a little bit. When do you seek some additional assistance? When the relief that you're getting is not good enough for you. If 2 to 3 weeks is reasonable for you, and then we also have to consider cost, downtime, convenience, all of that, we can offer a procedure like the medial branch blocks and radio frequency ablation that may give you extensive relief. So if you want to look at the individual factors like convenience, cost, etc., you may find that it's a wash, and if you have an option to get long-term relief versus just 2 to 3 weeks at a time, that may be worth exploration for you.
Minimally invasive surgery is used with a lot of complex looking stuff, but when it's all said and done, you are left with a little tiny incision and a lot less disruption, even though the equipment that's used to do it looks kind of crazy looking. But you're welcome to go back and take a look at that. It's amazing the genesis, the technology and seeing it evolve over the last 12 years has truly, truly been amazing. They didn't really do a lot of minimally invasive surgery when I was a fellow in Houston. And honestly, I had to kind of learn a lot of it on my own, just like doctors do all the time. They have to learn things that are new. If they're not in training, they've got to figure that out on their own when they get into practice. And so, and that happens constantly. It's a constant evolution of new procedures and new techniques. And spine surgery has definitely changed a lot in the last 15 years. Any other questions?
Okay.
All right, well, we thank you for coming, and hope we answered your questions.